All right. Okay, so last we left off on the AP lower ribs, and we're going to be picking it up today on a unilateral rib study. Now, normally when it comes to ribs, they're most often going to order those ribs bilaterally because the doctors do like to make comparisons between the right and left side. But some facilities do opt for the unilateral rib study just to focus on one side, that being the affected side of the injury, right or left. It doesn't matter if it's anterior or posterior, they're just going to focus on that one side. Now, why would they do that? Well, they would do a unilateral rib study just to zero in on one specific area of the ribs, because if you got less ribs in the x-ray, as opposed to having both on there, it's going to make the picture a little more clear so they can make more deep and accurate analysis if need be. Plus, it's also going to lower some of that patient dose because we're x-raying the overall torso, less of the body parts. But even with that being said, most of your facilities are going to opt for the bilateral rib study. This is quite rare. I've only done a few in my career as well. Almost every doctor just goes ahead and orders those bilaterally because a lot of facilities include that chest x-ray like we talked about last time. But if they do order it, how would you position for it? Well, you can do it either standing or supine, but much like the other rib x-rays we've talked about, preferably you want to do it standing up. That's going to be more comfortable for the patient and also going to give you a higher image quality overall. Now, when you're positioning the arms, you simply just have to have them by the side, but be careful on that. That's a little deceptive to me when it says arms by the side. You want to make sure, whether it's a chest x-ray or ribs, I often tell my parents, I almost tell my parents, I also tell my patients to lift their arms up a little bit. And the reason for that is if the patient has the arms relaxed completely by the side, like we see in this picture here, some of this arm tissue can actually start overlapping on the ribs. So even though it doesn't tell you in your book, my personal recommendation is have them lift those arms up slightly just to move some of that arm tissue, and it'll give you a clearer picture in case it's going to start overlapping the ribs on the side there. My parents are coming to visit this week. That must be why I said my parents. It's on my mind. So for the SID, that's still going to be at 40 inches, just like everything else we've talked about, with the exception of the lateral sternum. And for our CR, now right here I have the CR for the upper ribs and the lower ribs, because depending on your patient, just like bilaterally, if they have a very long torso, you may have to do an upper and a lower exam to get all those ribs and those x-rays. If they can all fit, it's great, but more often than not, you got to do two. So for the upper ribs on a unilateral study, that CR is going to be perpendicular midway between the MSP and the lateral margin. If you remember, MSP is essentially where the jugular notch and the sternum are located, right here. MSP being right here, lateral margin being right here. And I'm going to come back and talk about this in a second because I don't like this picture. I'll tell you why in a second. You're also going to put that CR approximately 3 to 4 inches below the jugular notch, basically T7, just like we would for bilateral. And if you're doing it below the lower ribs, it's going to be between the xiphoid process and the lower margin of the ribs. And I believe it was Jesslyn that brought it up last time. You can use that same technique of putting the lower portion of your light right at the iliac. It'll essentially put you in the exact location for those lower ribs. But just like with the upper, you want to have that halfway between the MSP and the lateral margin of the body because we're only doing a unilateral study. Now let me go back to this picture. Based on what I just stated right here, why do you guys think I don't like this picture? Does that look accurate to what I just described?
It's not 3 to 4 inches below the jugular notch.
Well, it's pretty much below the jugular notch, okay, but we'll look at the centering on the left to right margins. Does that look like that is halfway between the MSP and the lateral margin of the body? Not at all, not at all. Look, they're almost centered directly on the sternum, which is right here. So be careful. This picture's in your book, yeah? Is this picture in your book? Can't remember if this one's in your book or not, off the top of my head. If this is in your book, make sure you correct this. The centering is going to be right here. So essentially what you can do, guys, is put one hand on the patient's sternum, the other hand on the lateral side of the body. If you look at my cam, where I'm at, I've got one hand on the sternum, one hand on the lateral margin of the body. I bring my thumbs together like this, and that's the center between the two. That's where you'd want to actually center for that unilateral study. If that doesn't work for you, you can also, if you have pretty good x-ray vision, imagine where the nipple line of the patient is. If you put that crosshair right at the nipple line, that is halfway between the sternum and the lateral margin of the body, or MSP and lateral margin of the body. Two ways you can go about that. But be careful, if that picture is in your book, like I said, I can't remember off the top of my head, make sure you correct that because that's inaccurately represented. This actually would risk cutting off the ribs and you get too much of the other ribs as well. Not an efficient representation of that position. For your IR, you're still going to be using a 14 by 17. That's going to be lengthwise this time, by the way. So be careful because we got a lot of moving parts here. Not many positions, but a lot of shifting around of how we do cassettes, centering, breathing, and so on and so forth. If you remember, for the AP or PA upper ribs, we're doing crosswise cassettes. For upper unilateral ribs, we're doing a lengthwise cassette. So it's going to change. You're also going to collimate to the parts, which this person obviously did not do. We only want that one side of the body. So we essentially want, we're only interested in this right here. We don't want any light over here. So collimate that down. We only want to see that one side of the ribs. So same breathing techniques, guys. If we're talking about upper ribs, think of it like a chest x-ray. We're going to have them suspend inspiration, take our x-ray. If we're talking about the lower ribs, we're going to suspend expiration, just like we would for an abdomen. And then wall bucky versus table bucky, just like we would rather them stand, we would rather use the wall bucky over the table bucky. It's going to give us a much better picture overall. And of course, gonadal shielding. Gonadal shielding. And that would be your criteria for a unilateral rib study. So what's our criteria going to be? Here we go. So it does change a little bit from the bilateral study by what ribs are visualized. So for above diaphragm, in other words, the upper ribs, we're only interested in seeing 1 through 9. But we do need to clearly see 1 through 9. If 9 is cut off, that would not meet the evaluation criteria. For below the diaphragm or the lower ribs, we only need to see ribs 10 through 12. And once again, they need to be fully visualized for it to meet that evaluation criteria. And even though it doesn't state it there, guys, the same conditions apply. We want 0 rotation. We want good exposure factors. And we only want to see that one side. We want to see the side of interest. Once again, if I'm doing a unilateral left ribs, which you see right here, I'm not interested in seeing those right ribs. I only need to see these left ribs here. So this would be an example of a unilateral upper ribs or above diaphragm. Does this meet the evaluation criteria, yes or no? See some of you saying yes, and if you're unsure, let's count those ribs together. Let me get my marker out. Let's count 1, 2, 3, 4, 5, 6, 7, 8, 9. So we clearly have all the ribs that we need for that study. That would meet the evaluation criteria. We almost got all of them on here. 10, 11, 12 is just barely getting cut off. They almost got it all in one there. So once again, very rare is this exam ordered. Very rarely is it done. I would say you'd probably more so see this study ordered in a clinic as opposed to a hospital if they're going to order it. But like I said, I've only done it a handful of times in my career. We almost always do the bilateral ribs because the doctors love doing comparison views to make sure they're accurately reading those ribs, because ribs can be notoriously hard to read on a radiograph. Now we come to everyone's favorite. Oh yes, we love those obliques. I see you smiling. It's everyone's favorite positions. The absolute best. We love them. Don't worry, it's the same concept we learned for doing the oblique chest x-rays. It doesn't change much. We're going to go over it very slowly here to make sure we understand what's being visualized, because the key aspect on obliques that I want you to focus on, at least for my class, because you focus more on the positioning in lab, I want you to know what you're actually visualizing per oblique. It's very important to get that concept. So let's start by listing our criteria here, and we'll come back to these pictures and look at them a little more closely. So erect versus supine, you already know what I'm going to say. We prefer erect over supine, patient comfort and image quality overall. Now for our positioning, we're going to be doing a 45-degree oblique. That should be very familiar to you. It's the same way we do an oblique for a chest x-ray. 45 degrees being the most common oblique that we utilize in radiology. And that's, of course, going to depend on the area of interest, and you're going to raise the arm in a certain way depending on what you're looking at. Now, one thing to remember that can help you is you always raise the arm of the side you're visualizing. Now, that will change a little bit between an anterior versus posterior oblique, but one key aspect is I want to raise the arm of the affected side that I'm visualizing on that oblique. And then the opposite arm, I'm simply going to rest on my waist to keep it all the way. Don't let it dangle by the side for the same reason that I just told you guys on that unilateral. If those arms are hanging by the side, some of that arm tissue can end up obscuring those ribs and make it a little harder to visualize. We want it out of the way. And if you remember, I think I told you guys a cheat code on the oblique chest. If you look at the tiles on the floor, now this won't work in our new lab at the school, but if you have tiles on the floor, perfect square tiles, if you line up the patient's feet with the corner of that tile, that will usually equal an exact 45-degree oblique. Don't get too comfortable with that, because that will be going away in our new lab, because it's just plain wood floors without any squares anymore. Sorry to disappoint you on that. But if you have square tiles, that's a great way to get used to putting that patient in a 45-degree oblique, matching those feet up with the corners of those tiles. We're still at a 40-inch SID, just like the rest of our rib x-rays. Our CR is going to be pretty much the same as what we talked about with the unilateral upper and the PA and AP upper. We're still going to be 3 to 4 inches below that jugular notch. Our CR is going to be very similar to kind of what we just talked about with the unilateral study. We want the CR to be perpendicular, midway between the MSP and the lateral margin of the body. So you can use that exact same tactic I told you about. Either imagine where the nipple line is, put your crosshair there, or if you put one hand on the sternum, another hand on the side of the body, bring your thumbs together. In the middle of both your thumbs is where your crosshair will go. That's the tactic I use. And that's been the most accurate I have found. It works like a charm. You guys know what I'm talking about with that? I don't know if y'all can see my cam. Do 2 karate chops, one on the sternum, one on the side of the body, bring your thumbs together. That's the middle. And also, one thing to take note of, and I'm going to come back to this picture on the bottom left because I don't like how we did this. When it comes to obliques, where do we always center towards? I brought this up when we talked about SC joints. Where do we center towards on obliques? The upside or the downside? Correct, the upside. And that's very key to remember, because like I've said before, the biggest tendency I see amongst students and techs is they always like to put that crosshair toward the side down. We always, whether it's anterior or posterior oblique, always center towards the upside to compensate for the obliquity, because if we center towards the downside, we actually end up cutting off the anatomy we can see, especially on those anterior obliques. So be very careful with that. For the rest of this criteria, we're still going to be on a 14 by 17 cassette. Now, I'll make note of this as well, because it changes from those bilateral exams. We're going to be doing a 14 by 17 lengthwise cassette. And of course, collimating down to that part. If you have a lot of extra light on the sides or on the side that you're not interested in, bring that collimation in horizontally just a little bit. You can afford to leave it open vertically because we want to get as many of those ribs as possible. And then suspend the inspiration for these exams. We're going to suspend on inspiration and preferably use the wall bucky versus the table bucky, and of course, gonadal shielding. Now let's look at these pictures right here so we can identify what we're looking at and what we're interested in seeing for each of those x-rays. So first off, why would we do an anterior oblique? Specifically for anterior ribs. If there's an anterior rib injury, we'll do anterior obliques. If there is a posterior injury on the back side of the patient, we're going to opt for the posterior obliques. to look at those posterior ribs. If you get an oblique rib on an exam and it does not specify where the injury is, it's up to you based on how you question the patient or your own preference. So if you question a patient and they say, yeah, my ribs on my back are hurting, you as a tech need to say, well, I need to do what kind of oblique? Posterior oblique. If they say my front ribs are hurting, you as a tech have to think, I need to do anterior obliques to best visualize that for the doctor. If you ask the patient where you're hurting and say, I don't know, I'm not really hurting anywhere, then it's your choice, whichever one you're more comfortable with. Just make sure when you ask them that you do what? You document that they told you that. That way, let's say, for example, I asked, who do I want to pick on? I asked Luke, hey man, where are you hurting? And he says, oh, my front ribs are killing me. It hurts so bad. I take my x-rays, I get my PA ribs, I do my anterior oblique ribs, I send it to the doctor, and I didn't document that he told me his front's hurting. The doctor says, hey, John, I noticed that his posterior ribs are broken and you didn't give me posterior obliques. What happens? Well, I can say what I want, but I didn't document that Luke told me his front side was hurting. So make sure if they tell you something, I've said it once, I'll say it a million more times before you graduate, document what they tell you to cover your tracks. Because people misspeak all the time. They may not know the difference between front and back. English may not be their first language. Document what they tell you, that way you're covering your tracks. Now let's look at these pictures on the top left here. And I'm actually gonna blow this up a little larger so we can see it better. This is a great picture. There we go. Okay. So once again, guys, one thing I want you to remember is when it comes to an actual x-ray, if I show you a radiograph, I don't expect you to label it REO, LEO, LPO, and RPO because they're quite synonymous looking amongst each other. What I expect you to put is whether it is just basically oblique ribs. Oblique ribs. If you see an L, put left oblique ribs. If you see an R, put right oblique ribs. That's what I expect you to do on x-ray. But if I show you a patient like this, who's actually positioned, then yes, I need you to actually specify what oblique, because we can clearly see that on these positions. So on the top left is going to be an example of an REO, that's an anterior oblique. So based on what we've talked about before, it's the same concept with the oblique chest, what ribs am I visualizing on an REO?
It's going to be left.
The left ribs, exactly right. So keep in mind, when we look at anterior obliques, which would be the REO and LEO, I'm visualizing the ribs on the elevated side, which we see right here. On this REO, his left side is elevated away from the IR. Therefore, I'm looking at his left ribs. It actually elongates them on the X-ray. On the LAO, his right side is elevated. Therefore, I'm looking at his right ribs elongated. And that's specific to those anterior obliques. Now let's go down to these pictures down here. On his RPO, his right side is down, touching the IR. His left side is elevated. Therefore, on an RPO, what ribs am I elongated and seeing the best?
Right.
The right. Very good. The right. So for our posterior obliques, that be an RPO, LPO, I am elongating the side that is down. That's stretching those ribs out specifically. So for RPO, I'm better visualizing the right ribs. For LPO, I am better visualizing the left ribs. So it helps to write you out a little chart, whatever helps you with that. Make sure you remember and know what ribs we're visualizing per position. I might show you a picture like this, or I might just write it in text. I might say, what ribs are elongated for an LAO exam? You would select the right ribs, and I'll have all the choices there, and so on and so forth. What ribs are elongated on an LPO? You tell me the left ribs. So be very careful on that. Make sure you can distinguish the ribs, but also if I cover up this text and just show you a picture, make sure you can tell me if that's REO or LEO. Or if I was going to say it in text format, I might say the patient standing erect, his left posterior side is touching the wall bucky with his right side elevated away from the wall bucky. You tell me that is an LPO. So know it in picture form and know it in text form. I can ask it both ways. So can your registry, by the way. Making sense so far? We good? Good.
So is that specific? That's specific just when we're talking about like the chest, right? For instance, like, so if we're doing an RAO of the ribs, we're visualizing the left ribs.
Correct.
So, but like, so like if you did like an RAO for like the SC joint,
Mm-hmm.
then that there you'll be looking at the right SC joint.
Yes, you are correct. So I'm glad you said that, Jonathan. Don't mix that up with your SC joints. For SC joints, they're both anterior obliques, but we're looking at the side that is down on the SC joints. Whereas for ribs, we're looking at the sides that are up for anterior obliques. It's a good point to bring up. Shrink that back down. 1 second here. Now let's go back to this picture on the bottom left now. So based on what I've told you about the positioning, that guy on the bottom left, did the tech position that guy correctly? Yes or no? See, most of you saying no, and you are correct. Why is that not positioned correctly? Who can tell us?
It's not CP, I guess. It's a little bit rotation.
So basically, I don't know if that's what you said as size, but basically he's centered this patient right at the MSP. That's not where we want to center. We actually want to center towards the elevated side, first of all, halfway between the lateral margin of the body and that MSP. So be careful on that. That's how you would not want to position. I'm sorry, center for that patient. Position's good, but we've got our centering in the wrong area. Always make sure you're centered towards that elevated side. Otherwise, you're going to risk cutting off your anatomy because you're elongating those ribs quite severely. So let's look at a few x-rays here. So once again, guys, I don't want you to worry about labeling these on x-rays as REO versus LEO. I simply just want you to tell me it's an oblique rib. But this is what they would look like on x-ray. For this REO, if you remember, we're elongating the left ribs, which we see right here. Left ribs are elongated. The right ribs are foreshortened. LEO, we're elongating the right ribs and foreshortening the left ribs. And I forgot to bring that up when I was talking about the positioning. Make sure you know what's elongated versus what's foreshortened. So we elongate one side, we foreshorten the opposite side. So if I'm elongating the left ribs, I'm foreshortening the right ribs. That's for obliques. So we'd be going down here, LAO, we're once again elongating the right ribs, foreshortening the left ribs. For RPO, it's basically doing the same thing as that LAO. I am still elongating the right ribs, but foreshortening the left ribs. That's showing you right there how these exams are synonymous with one another. They elongate the same ribs, even though they're opposite positions. One would specifically let us visualize the anterior ribs better. The other would specifically allow us to see those posterior ribs better. I mean, posterior obliques for the posterior ribs, anterior obliques for the interior ribs. And then once more, if I showed you a picture like this right here on the bottom right, what position is this patient in? Correct, Jonathan, the LAO. Thank you, Aurora, the LAO. Make sure you can identify that. Still talking about the same picture. What ribs am I elongating on that LAO? The right. The right. I saw someone put left. Make sure you know it's the right. And what ribs am I foreshortening on the LAO? The left. Good. What side do I center towards on that oblique? The upside or the downside? The upside. Very good. Very good. So how do you feel about those so far? Pretty good? Is it making sense? Good, good. So on this slide, I know I already sent this to you guys. Make sure you correct this, guys, by the way, on your PowerPoint I sent you, because this picture had this labeled incorrectly. This should be for the right posterior ribs. This should be for the left posterior ribs, because when we do a posterior oblique, we are better visualizing those posterior ribs. I believe the picture said anterior ribs, so I covered that up. Make sure you do correct that on your PowerPoint so you don't mix that up. So two obliques here. What's an RPO? Elongating the right ribs, foreshortening the left. LPO, elongating the left ribs, foreshortening the right. And what would the evaluation criteria be? Well, here we have those exact things on the right on those bullet points. We do want to see ribs 1 through 9. That would be above the diaphragm. Same if we were doing the lower, which we'll talk about in a little bit, would be 10 through 12, because we do an oblique lower. The axillary ribs, they should be in profile with the spine away from the side of interest. Essentially, that means that spine needs to be rotated away from those elongated ribs and closer to those foreshortened ribs. And we want the entire ribs, the affected side, to be demonstrated completely. And that's why it's so important that we put our central ray halfway between the MSP and the lateral margin, because we do make those ribs much longer. If we don't do that, we risk cutting off the sides of these ribs. And that's probably the biggest mistake I see is people will do an x-ray and cut all this off. Very easy mistake to make, so make sure that centering is on point. And based on the evaluation criteria we see of ribs 1 through 9, I'll let you count that to yourself. Does that meet the evaluation criteria? Yes or no? Used to counting those ribs.
Yes.
Saying yes. All right, let's double check. It's okay to count them. I still count them myself. 1, 2, 3, 4, 5, 6, 7, 8, 9. So does it meet the evaluation criteria? Yes or no? We are cutting off the tip of that 9th rib. Therefore, this would not meet the proper evaluation criteria. Even though as a tech, we'd go ahead and just do a lower, which would be fine. If we're talking about optimal x-ray, meeting the evaluation criteria, this would not. This is tech centered a little bit too high. Make sure you get used to counting those ribs. So like I said, I might show you an x-ray that looks just like this, and I'll ask you, does this x-ray meet the evaluation criteria of including all the proper ribs? Okay, our last position in this chapter is going to be the oblique ribs below the diaphragm, or oblique lower ribs. So positioning wise, it's going to be very similar. In fact, it's going to be exactly the same as the upper. The only difference is we're changing where our CR goes, changing that location. We're still going to be erect, preferably, although we can do it lying down if we wish. And that posterior oblique is going to be a 45-degree oblique, with the area of interest having the arm moved out of the way. I'll just put it above the head, just like with the upper, personally. The arm on the unaffected side will be moved out of the way as well, so we don't have that overlap. Still at a 40-inch SID, the CR will be perpendicular midway between the xiphoid and the iliac crest. Know that that's halfway between the xiphoid and iliac crest, but the same tactic works if you put the bottom of your light at the iliac crest. That essentially centers you correctly for that lower ribs, that little cheat code way you can do it. And we are using a 14 by 17 lengthwise. collimating down to that part, taking off some of that excess light, and make sure you know that that breathing does change between the upper versus lower. Once again, instead of inspiration, we'll be X-raying on expiration, because we're in the abdominal area. Wall bucking versus table bucking still, the wall bucking will be preferred, and then we're going to use that gonadal shielding. Now, as far as what ribs we're looking at, it's the exact same concept with upper, that does not change. Therefore, the anterior obliques would be visualizing the elevated side. The posterior obliques would be visualizing the downside, even on those lower ribs. That does not change. And then once again, look at this right here. Is that central ray in the right spot? Yeah, for some reason, these books, it really gets on my nerves. These books, they really like to put that at the MSP, and it's incorrect. The official positioning should always be right here, guys, halfway between the MSP and the lateral margin of the body, essentially on the nipple line of the patient on that elevated side, to correctly have all those ribs on X-ray. Otherwise, they will not be represented correctly. They'll be cut off. We have to do this for obliques, or it will not be positioned correctly on the X-ray. If this tech took this X-ray, even though it looks like we have all the ribs on there, we'll actually be cutting them off, because the way the ribs elongate on the oblique stretches them out so severely, this actually would risk cutting those ribs off. So make sure you are centered towards the elevated side, halfway between the MSP and the lateral margin of the body. And that's going to be essential when we get to L-spine as well, a couple of chapters. And that's what it's going to look like right there. What do we have to have for that evaluation criteria? Even though it's not on this bullet point, make sure you write in, we do need to see ribs 10 through 12, as opposed to 1 through 9. And we want the axillary portion of those ribs to be elongated. That's why we're doing oblique, no motion, and of course our optimal exposure factors. So looking at this X-ray, I don't even think I have to really say, does that meet evaluation criteria? Do we have ribs 10 through 12? Yes, we absolutely do. We have a lot of ribs on there. We almost got full set of ribs on there, matter of fact. But yes, we do have 10 through 12. This tech personally centered way too high. Wouldn't repeat this necessarily because we have it all on there. But once again, for an optimal image, we actually just center that lower because we already included most of those ribs on the upper rib X-ray. There's no need to have all those ribs once again overlapping like this tech did here. So acceptable, but not optimal on this X-ray here. All right, that wraps up our positioning for this chapter. Yay, we're done with that. So now we are going to evaluate a few more images just to make sure we know what's an optimal image, make sure we know the evaluation criteria, because we are going to start introducing a lot more of that to you guys because the registry is pushing that a lot harder these days about how to identify optimal versus acceptable images. And you're actually going to have an entire class on this next fall about identifying these types of images. So with that being said, let's look at this set of 3 images we have here first of all. And let's look at the image on the top left. First off, what kind of X-ray is this? You can tell us. What are we looking at here?
Sternum, oblique.
It is an oblique sternum. And what would be the actual position of that, Daniel?
RAO.
Very good, the RAO. RAO. So let's look at this image a little closer. And would you say, Daniel, I'm just going to stick with you since you spoke up first. Would you say that this is an optimal or just an acceptable image, Daniel? What do you think?
I'm gonna go with say optimal.
You're saying optimal, and why would you say it's optimal?
It looks a little dark to me as far as technique wise.
It does, yes. So I would say this is probably close to optimal, but not quite. Even though we can't really even see the sternum very well, it's actually positioned quite good. This is what I was telling you guys before, that REO sternums are actually notoriously hard to visualize. It's very rare that you're going to get a very pretty image. But what Daniel brought up was the technique is too high. We've got way too much blackness on the lungs here. We can't hardly make out anything. Positioning is good, but we also have way too much light on this x-ray. We collimate that down. Now, where's the sternum on there? Believe it or not, this is actually the sternum right here. That's the sternum. Would you have ever guessed that? A little hard to see, right? So we'd actually edge enhance that x-ray, or the radiologist would edge enhance it to better make it out. But this would be basically an acceptable x-ray, but not quite optimal, because we've got too much light on the sides and the technique's too high. Now, had the tech brought that collimation way down, guess what would have happened? We would have brightened up the sternum even more, helped us visualize it better. That goes back to that point of telling you guys that collimation really does make a difference. Even though a lot of techs will tell you it does not. When it comes to these very specific exams like the sternums, collimation is going to be key to getting that optimal, beautiful image. Would we repeat this? No, we wouldn't repeat it, because the doctor can edge enhance it, but we would not call that an optimal image and be on the acceptable territory. Let's go to the left, I'm sorry, the right, and I'll let someone volunteer, or I'll volunteer somebody on this. What kind of x-ray are we looking at in the top right? What is that?
Lateral sternum.
Okay, Asias, thank you for chiming in. So this is going to be yours, Asias. It is a lateral sternum. So Asias, let's pretend you're the QA tech for the day. You're the quality assurance technologist, and I just sent that image to you. I said, man, Asias, I'm so proud of this lateral sternum. It's the best one I ever made. Would you send that to the radiologist, yes or no? What do you think?
No, I'm not gonna send it.
Oh, you're gonna hurt my feelings. I worked hard to get that x-ray. It's so insensitive. Well, why, Asias? Why can't I send that image to the radiologist? What's wrong?
I would say the technique wise was incorrect, as well as that we clipped the xiphoid process.
Correct. So the xiphoid process is cut off. What else?
And then no marker.
No marker. Correct. So basically, this tech got a little too crazy with the combination. So we cut the xiphoid process completely off, which is down here. We also cut what off? What's that called up there?
Membrane?
Membrane. Completely cut that off as well. Now, this tech had the right idea. I mean, we had pretty good collimation. It's a pretty good quality x-ray as far as the bony detail, but we're clearly missing the appropriate anatomy. And just for fun, Asias, what's that SID for that exam?
72 SID.
Very good.
It looks like 40 SID. I mean, it's so magnified.
And that's a good point too, Asias. This could also be an example of someone that used 40 SID, not necessarily collimation. Because what happens when we bring it closer, it's going to magnify that part. So this is either too much collimation or a magnified body part. Two issues going on there. Clearly, we're cutting the top and bottom off that sternum. We need to repeat that x-ray. Let's go to our last one on the bottom here. And who wants to be my volunteer for that last one on the bottom? And we're going to pretend this does have a marker right away, since we already brought up the marker stuff. Who's my volunteer going to be? Who wants to be QA tech? All right, Jessla, you look like we're really focused on that. You're going to be the QA tech. You look like you're really focusing hard on that. So take it away. Is that acceptable if I sent that to you with a marker on it?
I want to say, but I want to say yes.
Well, then say yes. So Jesse's saying yes. Does everyone agree? Or does anyone disagree?
Yeah, I'm doubting myself.
Well, why don't you explain, Jesse, first of all, explain why you're going to say yes.
Okay, so if we're looking, okay, so the whatchamacallit, the Zypher, I can't tell, is that on there? I think
It
it's,
is.
okay, so it's on there. And, okay, so you got the whole sternum, but
Yes.
I don't know, maybe they got the ribs too. So I'm gonna say yes. You can see everything. You can see a little bit of the ribs. I mean, you don't need to, but it's there.
So overall, you're correct. This would definitely be an acceptable image. We would pass this if the marker was on there, of course. We're pretending the marker is on there.
Okay, then yeah.
Now, if I wanted to be super nitpicky, yes, we could cut some of this off. We don't need all this ribbon, but we definitely have the entire sternum visualized. They did attempt to collimate, and the reason why it's going at an angle is they tilted their tube, which is acceptable. That's a technique some people do to line up with the chest. So overall, yes, it's a pretty good lateral sternum. Not optimal by any means. It's hard to get an optimal image. It's basically perfect, but definitely passable and acceptable. Would send that through and not repeat it. So we got everything we need to see.
I think I was a little bit the ribs, you know, because you don't really need it. Your sternum, so I guess.
Right, right. Good. Well, let's look at these two here. We'll look at this image on the left side first. Do I have any volunteers for this one? Any volunteers out there? All right, who am I going to pick on then? Let's see. Ruth. Ruth, this one's yours. First off, what are we looking at here? What kind of position is this patient in? What is this? What body part position?
It's a PASC joint.
Very good.
Left. We're looking at the left one, but the right AC joint looks open than the left one.
Very good observation. So we are looking at both SC joints for a PA. You are correct. Is the centering good? You think the centering is good?
Not really, because it's supposed to be, I don't know if it's the left one was supposed to be open, but if it's the left one, it's not, the centering is not correct.
Well, you're on the right track about the right one being open. That means the patient wasn't completely PA. But we are centered overall correctly on the cassette, because if you remember, guys, for a PA SC joint, we actually want to see both of them closed, both SC closed. And clearly, as Ruth pointed out, the right one is slightly open. What's that tell us, Ruth?
The rotation, the patient did move his head.
He either turned his head or he had his shoulders obliqued, most likely. But you are correct, this would be PASC joints. We're centered overall well. The only deficiency we have is that that right one is slightly open, which tells us either he had his head turned to the side or his shoulders are slightly obliqued, opening up that SC joint, because we do want to make sure that both joints are closed for a proper PASC joint. Good. Also, you guys know my biggest nitpick, right? Is that marker in a good spot? No, look, we need to put that marker here. Because what if there were some rib fractures we were covering up? That'd be a big no-no. Or some kind of pathology on the lungs. All right, thank you, Ruth. Let's go to the image on the right. And Son, you look like you're itching to talk about this one. What are we looking at here?
I'm looking at the chin, right? The chin. see the chin clearly, we need to like face up a little bit.
Oh, did I lose you guys? Can you hear me?
Hello?
All right, so go ahead.
The chin,
I think we're having
chin goes
There we
over.
go.
I'm sorry. Do you hear me?
I can barely hear you.
Oh my god. The chin so low.
I think we're having some technical difficulties here. Let me go ahead and go through this one so we don't run out of time here. I'll take it, son. Thank you, though. So this is pretty optimal, acceptable overall. Why? Because we do have a nice, clear, open right SC joint, by the way. I'm sorry, left SC joint on that right side, the left SC joint, which means they were obliques properly, with the left side down, the right side elevated. Therefore, that patient is in LAO position. The head is turned towards the affected side, and the anatomy is overall centered to the right area. So this would be pretty close to an optimal oblique SC joint. I could have cleaned up the collimation slightly if I want to be super nitpicky, but overall, well done. Let's look at these two right here. Real quick, let's go to, Amy, why don't you take that image on the left side there? So we're gonna pretend this is a upper ribs X-ray, by the way. So can you evaluate that for us?
I think it's a good image.
You think it's a good image?
Well, it's missing the marker, that's for sure.
It is, definitely. So if the marker was on there, though, what do you think?
I think I would send it.
And you are correct. This would be definitely almost optimal because we have all the ribs we need to see for the upper ribs X-ray. And if you remember, if I give you an image like this, you're going to assume it's an AP upper ribs, by the way, because that's the more optimal image overall, because we're going to visualize the posterior ribs. Only thing we're really missing is just the marker. We're centered well. Collimation looks great. We've got air-filled lungs. This is as close to optimal on an AP upper ribs as you can almost get. Now, I can be super nitpicky and say we could slightly collimate a little bit of the top off, but then you're going to risk cutting off some of the ribs. So this definitely be a great overall exam. Let's go to the one on the right, and I'm going to give that to Esbede. What are we looking at here? And is this a good exam or does it need some work?
I'm actually kind of confused on the ribs. So I'm looking at an, I think I might be wrong.
Can you repeat what you said, Esbede? You were cutting out. Couldn't hear you.
I think I'm looking at an LPO. I think.
And when I show you a radiograph, you simply just have to say oblique ribs. You don't need to see LPO or any of that.
Okay.
For the X-rays only.
Okay. And then I think that's. I think it's like 1 through 9.
You think it's 1 through 9 on there?
Like well, for like big ribs, you need to have 1 through 9 the diaphragm, right?
3, 4, 5, 6, 7, 8, 9. Definitely all on there. So yes, you're correct. Anything else?
And it has its marker. It's a good image.
And I agree. Overall, it's a good image. I think we centered a little bit more towards the elevated side because we have a little bit too much of the foreshortened side on the x-ray. Like we can cut some of this off. So I think our steering could have been a little bit better, but we would not repeat this x-ray. We've got our marker. We've got everything we need to see right here. Overall, the technique is great. So definitely a passable, acceptable image. It does meet the evaluation criteria overall, yes. All right, so I want y'all to really watch out for that, guys. When it comes to rib x-rays, make sure when you're counting those ribs that the ones you need to see aren't cut off. For example, if this collimation had been a lot tighter, and let's say all this was black down here, this would not meet the evaluation criteria because we're clearly cutting off that 9th rib. Definitely make sure you work on counting the ribs properly. That's going to be key to doing some of these labeling and questions on your next tests. Make sure you count those ribs correctly. Registry loves to do that as well. They like to make you count ribs. And do keep in mind, once again, guys, I know I said it before, all this beautiful anatomy we've talked about before is still fair game as well. Y'all know that's my favorite one, so you can probably expect that to be on at least one of your images. Coracoid process. Yeah. And last but not least, let's look at these last two images here. And let's go to Aurora. Aurora, why don't you take that image on the left? First off, tell us what we're looking at, and do you think that is a good or bad image as far as evaluation criteria?
I think it's a unilateral rib.
It is unilateral rib, you're correct.
The 9 ribs are showing, so that's good, right? Did I count that right?
You did, yes, you did.
I think it's a passable x-ray.
It definitely is. Good job. It definitely is. We've got all the ribs we need to see. In fact, we've got all 12 ribs on there. Did you notice that? We got every single rib on there. The only thing I would say, like, I know you guys have not learned a lot about techniques yet. The main issue I see is this is way overexposed. See how black that is? Maybe there's way too much mass on that x-ray. But based on what we've talked about, this does meet all the criteria of all the ribs. We've collimated down to one side. We're centered perfectly between the MSP and lateral margin. The only thing we're missing is that wonderful left marker right there. Had they put that marker on there, that'd be pretty much optimal aside from the dark lungs. But good. Good, good, good. And our last image here, let's go to Jonathan. Why don't you bring us home on that one? What are we looking at? Do you think that's a good or bad image? What's your opinion?
Okay, so this is so AP lower ribs.
Yes.
Let's see, you clearly see 10 through 12. They're not standing straight because there's some scoliosis going. But
correct.
Is it? I mean, is that too much? Is that too low?
Good observation. It's definitely too low. Definitely too low. Because we got almost half the pelvis on this x-ray. So where should the centering actually be based on what we talked about?
Between the xiphoid process and the lower rib margin?
Correct, correct. Or if you want to use the cheat code, instead of the bottom of the light being down here, put the bottom of the light right here and you'll be in the right spot. So halfway between the xiphoid process and the lower rib margins where we want to be. So this all is unnecessary down here. Even though we have all the ribs we want to see, which is 10 through 12, This is way, way too much overkill on the rest of this patient. This patient got way overexposed for no reason. We do have a nice marker, which I'm glad to see. But yes, definitely need to work on that collimation. It's good. By the way, fun fact here, I don't know if I've ever talked to you guys about this. Actually reminded me of when I was in school, because I use different markers than the ones you guys are using. Does anybody know what this is? This is kind of old school.
Aren't those beads in the markers that tell you if the patient is standing up or laying down?
Very good. Where'd you learn that from, Delisha? Did someone tell you that, or did you just know that?
No, when I was looking up for my own markers before we started the program, I was noticing a lot had beads, researching into it.
Okay, okay. So yeah, most markers, and this is the way mine looked when I was in school, used to have this little area right here, this little circle with 3 little metallic beads in there. And if the beads were at the bottom of the circle, that told you the patient was standing. If they were in the center, it told you the patient was lying down. It's a little indicator in case you didn't label it correctly. It's a fun little fact there. Which I think it's a good idea. They ought to keep them on there. I think it's a great little way to check yourself. Let the radiologist see. All right, before we take a quick break, are there any questions on the PowerPoint, on the positioning, on anything we just talked about?
Yeah, just one more time. For the chest anterior oblique, you're visualizing the opposite side.
For the anterior obliques, the elevated side, yes, is what's being elongated.
Okay, and then but for the SC joints, anterior oblique, we're visualizing the downside.
Correct.
Okay.
Correct.
I just get those confused, so.
It's an easy thing to confuse because they're both interior obliques, but they are looking at completely separate areas.
Okay.
Yes. All right, guys, we'll go ahead and take a 5-minute break. Let's come back at 12:50 and we'll look over your charts. Make sure you have that chart I sent you in the email ready to go. We'll make sure you have all the accurate info for your studies on that test on Friday. See you guys in about 5 minutes. Towards the elevated side.
Mr. Donahue?
Yes.
On the AP below ribs, is it between the xiphoid process and the lower rib margin, right?
You are correct. Thank you.
Okay, just making sure.
Thank you. Fix my typo there. Thank you. Where was I? Down those. So for part positioning, for our AP bilateral ribs above, that's going to be the shoulders rolled forward, erect position, much like we would for a chest X-ray. The AP bilateral ribs below, arms away from the sides. I did add that in there. That's not officially part of the positioning. That's a good thing to make sure you remember. Otherwise, we're going to have the arms covering up the ribs. Erect would be the preferred method to have that patient standing. For the PA bilateral ribs above, shoulders roll forward and erect is the preferred position. Unilateral ribs still erect. I'll put arms away from the side there as well. Sorry, I'll type this up really quick here. For those oblique ribs anterior, that's going to be oblique 45 degrees, affected side arm up. We'll put that in bold because that's very important on those obliques. Make sure that affected side arm is up and unaffected arm is on the hip for both the obliques. For the LEO, REO, LPO, RPO, whatever side we're visualizing is the arm you need to have up above the head. Take note the way that the inspiration versus expiration changes. If we're talking about upper ribs, it's always going to be inspiration. If we talk about lower ribs, it'll be expiration. Think of it like a chest X-ray versus abdomen X-ray. I mean, leave that up for a second and I'll still copy. Try something here. Is that too hard to see, or can you guys see that? Is that too small? Do I need to zoom it back up? Okay. So leave that for a couple more minutes here while you guys still copy. Keep also adding the orientation on here, guys, if that helps.
Yeah.
Are we okay if I start scrolling down? And what helps me is you see these little inconsistencies like this lateral sternum being 70, put that in red, bold, so it stands out to you. So that's the only one that's 72 inches. Something for you to remember. Same with these SC joints. If those little inconsistencies where things change, a little bit of different color. Okay, start scrolling down a little bit more. This is going to be your evaluation criteria down here. Just add a few little more notes on there for you. Some little short notes there to help you. Hope that helps. And with that being said, guys, there's about 5-6 minutes left. You can still take as much time as you need to finish copying this. Whenever you are done, you are dismissed. For Wednesday, we'll do a review together. I'm gonna have a practice test for you guys, and we'll go over any other information that you may be having trouble with. But once you're done, you may go. So have a good evening, and I'll see you guys on Wednesday.